And just in general, we want to make sure to encourage her. As was just shown in the role play, we want to be there for support and encourage her, positive feedback through the CBT process and encourage skills that she learns. So the best outcomes for pain disorder for Pam's case is to reduce the severity and frequency of the pain she's feeling. Unfortunately, somatoform is difficult to treat. Kroenke states in an article that both in terms of outcomes and the interaction between clients and practitioners, it's again difficult, and those are obviously two major factors. Also, the rate of, can't say that word, so the rate of clients returning back to treatment for more is about 30% to 50%. And this is for somatoform, where for most mental health disorders, it's about 15%. So it's obviously a really big increase. And that could be showing that psychotherapy perhaps isn't as durable as a treatment, or it could be just the long-standing pain they've been feeling. There's a lot of factors that go into that. So the expected results from the research, as mentioned before, CBT is the most studied, and Allen and Wolford found a greater reduction in pain associated with CBT compared to the other treatments that the other Ali mentioned. And in one of their studies, 40% of subjects had clinically significant improvement, and that's defined as being much improved on a clinician-rated somatoform severity scale, so like an outcome study, very official type scale. And also CBT is associated with enhanced physical functioning with the reduction in pain and reduced healthcare utilization. Medication, antidepressants are promising, but more studies and outcomes are needed. And as Ali mentioned before, the tricyclic antidepressant medications are very effective for headaches, which we know in Pam's case would be really helpful for her. And for family therapy, Reel and his colleagues, unfortunately it's an older study, but we had a hard time finding outcomes with this. Brief strategic family therapy was 61% effective for about 18 subjects with somatoform. So that's a very good option. And we didn't include this on the slide, but we had some trouble also finding recent outcome studies for both assertiveness training and couples therapy for somatoform specifically. But due to her family dynamics that we've discussed, and especially how Pam has a lot of trouble both with her husband and with an old boyfriend, the first time she had sex, being able to just say what's on her mind, say no. So we think this, this would be really appropriate supplemental treatment for her. And for establishing baseline functioning, Pam's going to complete her pain log for the first 2 weeks of treatment, and we're going to review that. I won't go into that too much because Lynn already kind of described that. And then we're also going to look at her score, also midway through treatment and at discharge, but especially at intake for her SOMS score. So that's screening for somatoform symptoms. That will tell us a lot about the type of symptoms she's feeling and how much it affects her and many other things. So for measuring outcomes, we're going to measure Pam's self-report. So every session we'll have her rank from 0 to 10 the amount of pain she's feeling, in terms of severity. Also, as I mentioned before, her pain log is going to tell us a lot about the frequency of her pain, the onset, what's going on psychologically when she feels it. And also, as previously mentioned, the SOMS score will be a really good indicator. And also healthcare utilization, because we did discuss this before, but if Pam's going to her medical doctor still every week for pain medications, clearly she's not feeling better, and perhaps our outcomes aren't as good as they should be. So that'll be really important. So now I'm going to pass along to Marisa, who's going to talk about legal and ethical issues.
So anytime we are working with an interdisciplinary team, we have that many more legal and ethical issues to consider. So being that somatoform disorders are generally going to be treated in an interdisciplinary setting, we have to deal with all the legalities of the medical field. Excuse me. So as mentioned before by some of my colleagues, medication-seeking behaviors are actually very prevalent among these patients, understandably so, because they've seen many doctors, they've gone through the traditional routes to seek treatment, and they're really not getting any relief. So we have to be very aware of our patients' tendencies to potentially doctor shop, which is the term used for seeing multiple doctors as if that's your first time seeing a doctor for that disorder, and then perhaps having a prescription assigned to you and using the prescriptions for multiple doctors, not as they were intended. So we have to be very careful of controlled substance use and prescription substance use, and really just be mindful of that. I think that's a legal and an ethical obligation of us to inform our participants of what implications those actions might have, and just be mindful of substance abuse issues before they arrive. If they're under our treatment, we need to be monitoring for that. And one thing that I think that my fellow presenters did a really good job of describing was that the pressure on the doctors sometimes to make a diagnosis leads to a lot of bias in the medical field. This is a really big ethical issue when working in an interdisciplinary team in general, just having different perspectives on the same problem. And in the case of somatoform disorders, there is a pressure for doctors from insurance companies and internally as kind of some of the authors have theorized it's kind of an ego issue for some of the doctors to not be able to assign a diagnosis to what they call medically unexplained symptoms. And so a lot of times they are misdiagnosing. They're kind of trying to make patients fit into a box and potentially even prescribing or enacting treatments with those patients for a disease that they may not have. So I feel that this makes our role as a social worker even more important to educate our colleagues in an interdisciplinary setting about this whole category of diseases that they may not have even thought about, and also just to ensure that our clients are getting the best possible medical care. And it's actually been shown that 90% of doctors see an overlap or perceive an overlap between what they would call pain disorders or somatoform disorders and hypochondriasis, malingering and factitious disorders. So essentially that is to say that most doctors feel that this is feigned, that the patients are faking it, or that it's not real pain, and so that just is another bias that we have to counteract. And similarly, transference and countertransference issues will come into the therapeutic relationship almost certainly, because our patients, by the time they see us, have likely been through multiple doctors who have told them it's not real. They may immediately assume that you're not going to validate what they're going through. And likely, countertransference issues can happen as well if you're working with somebody who has, let's say, a personality disorder and a somatoform disorder. It may be hard to distinguish out some of the manipulative and emotionally crutch behaviors that they have with the actual legitimate pain that they're feeling. And last but not least, we just need to work to reduce the stigma associated with this disorder because there are so many doctors that are kind of blurring them together. We need to ensure that our clients and medical practitioners are aware of this whole category of disorders that can be experienced. And lastly, we wanted to touch on our group diagnostic process. Ali mentioned it before. We had kind of a hard time wrapping our hands around this at first because it is so strongly medical. So when we're doing Axis 3, we're like, are we sure we can't diagnose her with anything medical? So it's a little confusing. So we were confused at first about the actual medical diagnosis and just feeling as clinicians, if we were in that situation, we'd want to be really sure that there wasn't any underlying medical condition that we were encouraging her not to treat, and treat psychological factors instead. And we did have a little bit of a countertransference issue with Pam, being that we're all graduate students and we're all stressed. It's kind of a stressful period in our lives. We could kind of relate with the symptoms that Pam feels when she is stressed and how I'm going through my final season cold right now. I'm sure we can all relate to just kind of feeling bodily drained when you are going through a lot of stress. And Allie had a story she wanted to share as well.
Yeah, when I was in high school, I had some syndrome that's totally fixed now, but it basically gave me blood clots. So I had to be in the hospital like on and off for like a month. And I was bored, I was like 17 years old. I felt fine. I was bored. And anyway, so after surgery, I'm in the hospital, and the nurses made a point that whenever my friends were in the room with me, I never ever asked for painkillers. Because I was so, obviously I'm a teenager, I'm happy to be with my friends, I don't care if I'm in a hospital bed or a playroom or whatever. And basically every time the second my friends would leave, I obviously felt isolated, I felt lonely, I felt a little depressed that I was even in the hospital, and then I would ask for painkillers. So I always thought that was very interesting how I just, pain came right back when I wasn't feeling so great. So, thanks for sharing that.